Assalamu alaikum wa rahmatullahi wa barakatuh. Hello everyone, my name is Dr.Rasha and I'm the president of the Emirates Society of Emergency Medicine and an assistant professor of emergency medicine at Mohammed bin Rashid University of Medicine and Health Sciences. It is a great pleasure for me to be here with you today at the first Libyan Emergency Medicine Conference. I would really like to thank the scientific committee for inviting me to present to you today on the use of point-of-care ultrasound in resuscitation. Before we get started, I don't have any conflict of interest to declare. And I just want to give you a little bit background about myself so you can understand my enthusiasm for the subject of point-of-care ultrasound in emergency medicine. So I went to medical school here in the United Arab Emirates, in Al Ain, in United Arab Emirates University. And I did my residency training in George Washington University in Washington, D.C. in US. And then my passion and enthusiasm for ultrasound led me to do a point-of-care ultrasound fellowship at Mass General Hospital in Massachusetts. And in 2014, I completed my training and returned to the United Arab Emirates. And since then, I've been practicing emergency medicine, teaching point-of-care ultrasound in many regional, local, and international conferences. And currently, I also help and supervise residency and fellowship training programs here in Dubai. It is a great pleasure for me here today to discuss with you my enthusiasm about point-of-care ultrasound, and specifically we will address the use of point-of-care ultrasound in resuscitation. How about you? Do you use point-of-care ultrasound? Have you ever get trained in it? If not, I hope this lecture will be intriguing for you to pursue further training. I know my colleagues in Libya have been doing a lot of training in point-of-care ultrasound, and hopefully we can collaborate in this because I think point-of-care ultrasound should be part of the emergency medicine practice worldwide. So let's get started. So you are in the emergency department and you get a call that there is a patient who is coming to you who has a witnessed arrest, and the paramedics inform the department that this patient was in PEA, pulseless electrical activity. When the patient arrived to you, you implemented the resuscitation protocol, the ACLS protocols, with chest compressions and ventilations. This patient is in PEA, so you don't need to deliver any shocks. You continue with your chest compression. And one of the doctors in the resuscitation bay told you, should we do ultrasound for this patient? Yes or no? So this is a very interesting questions. Ask yourself, do you use ultrasound when you actually resuscitate a patient? This conversation started in 2015 when the American Heart Association published their Adult Advanced Cardiac Life Support statement. And what they said in their statement that ultrasound, cardiac and non-cardiac, may be considered during the management of cardiac arrest, although its usefulness has not been established. So this was, intriguing for many healthcare providers. Should we use ultrasound? So they said it may be considered as part of the cardiac arrest management. And they also elaborated more. If a qualified sonographer is present and use of ultrasound does not interfere with the standard of cardiac arrest management, then ultrasound may be considered as an adjunct to the standard patient evaluation. So based on this, you perform your ultrasound. You found a sonographer who was able to actually do a cardiac ultrasound, and the sonographer told the team leader, this is what I see. So now what? What will this information add or change in your management of this patient? So the objectives of this session is to present and hopefully try and answer these questions. When should you use ultrasound in cardiac arrest? How should you use ultrasound in cardiac arrest? And finally, why should you use ultrasound in cardiac arrest? So you all take care of patients in cardiac arrest, right? So you have a patient who comes to your department in active cardiac arrest, CPR is ongoing. Immediately you will attach the patient to the monitor, and these are the various options that you will get, right? The patient could be either in asystole, Patient could have organized cardiac activity but no pulse, so PEA. Patient could be in VTAC, ventricular tachycardia, or can be in ventricular fibrillation. The question is, which patient should you actually perform an ultrasound on? The first two rhythms are the non-shockable rhythms, and the last two are the shockable rhythms. So, definitely point-of-care ultrasound is recommended in the non-shockable rhythm, which is pulseless electrical activity and asystole. However, point-of-care should not delay life-saving treatment in ventricular arrhythmia, whether it was ventricular tachycardia or ventricular fibrillation. Because what is our priority in shockable rhythms? Absolutely, is shocking the patient, delivering that shock, and doing high-quality CPR. So if ultrasound will not delay the management of shockable rhythms, yes, then it can be used. However, it should not be the priority in these cases, because your priority is delivering the shock. So in general, we recommend the use of point-of-care ultrasound in patients who have non-shockable rhythm, which is PEA or asystole. Now, how should you incorporate it? This is just the algorithm of cardiac arrest that AHA use. And it looks like a very busy slide, right? You can see between CPR, rhythm checks, delivering the shocks, giving them supplemental medications. So where in this busy algorithm should point-of-care ultrasound be done? This is a very, very important question, because every minute and every second of the resuscitation matters. And we want to make sure that point-of-care does not interfere with the regular protocol. So what is the recommended time, location? How would you actually perform ultrasound during resuscitation? So this is a sample algorithm of how you should incorporate ultrasound in your cardiac arrest. So you will start up here. You have an ongoing CPR. And again, remember, these are non-shockable rhythms, either PEA or asystole. And you will have, obviously, CPR is ongoing. This is the cardiopulmonary resuscitation panel, and this is the point-of-care ultrasound, that they go parallel to each other. So you will focus on your CPR algorithm, where you will do the chest compression alternating with ventilation. Ultrasound should be done during the pulse check. You see here, so you will prepare to do the ultrasound few seconds before the pulse check, and you will immediately do it during the pulse check and record the videos. And this is very, very important. You have less than 10 seconds to get the ultrasound view that is needed. And during your performance of the ultrasound, you will record these images, and you'll see that image interpretation of the findings will happen once CPR has resumed, because you really do not want to delay the 10 seconds of pulse check because you're trying to get the ultrasound image. So remember, you have to prepare for the ultrasound just before the pulse check. You will perform the ultrasound during the pulse check and save the image recording, and you will interpret your ultrasound finding once CPR resumed. And this is very, very important, that your pulse checks will be done, especially the cardiac views will be done during the pulse check. And your ultrasound should not interfere or delay the pulse check and increase the interval, because we want to minimize the interruption of our chest compression, and we want to increase the CCF. So this is very, very important, that when you use point-of-care ultrasound in cardiac arrest, you do not want to interfere with the standard protocol that is known to that high quality CPR, minimizing interruption is the priority. So this is again a quick summary of where should you do your ultrasound within your cardiac arrest algorithm. And this is just an algorithmic or schematic representation. This is your compression zone. So here is where basically the compressor will be placing their hand. Very important that we try not to use the compression zone and perform ultrasound in because when you use the ultrasound, you'll need to use gel. And if you had to use the compression zone, make sure you have a towel in the other hand to clean the chest immediately just before the compressor will resume the chest compressions. So you will see, you will do the different views. Here you will do your cardiac subxiphoid view. Here's your cardiac apical 4. Number 3 is looking at the lungs. And number 4 will be looking in the abdomen for any free fluid in the abdomen. So again, try your best to avoid the compression zone, especially if you're able to get a good subxiphoid view in an apical 4. If you can't for any reason and you need to use the parasternal long or short view here in the compression zone, make sure you have a towel that is available to you in your other hand to clean the chest and remove the gel before they resume the chest compression. Otherwise it will be slippery and the quality of CPR will be affected. And this is a protocol that was published. It's called the CASA Protocol. It's the Cardiac Arrest Sonographic Assessment Protocol. Always when we use protocol, it helps us to become standardized, systematic. So what does this protocol entail? So this protocol specifies every pulse check what you should be asking yourself and looking for. So the first time they actually pause CPR to check the pulse, you will do a cardiac view in the subxiphoid or apical, and you will ask yourself a specific question: is there cardiac tamponade? So you will do a subxiphoid view, record the video, and once they resume CPR, you will look at that video and answer, is there cardiac tamponade, yes or no? And in this video here, you can see this is the heart and there is pericardial effusion surrounding the heart. So then CPR will resume. After that, in the second pulse check, again, you will do a cardiac view, apical or subxiphoid, and you want to try and answer the second important question: are there signs of right ventricular strain? And we know right ventricular strain is a sign in cardiac arrest that could be that the right ventricle pressure is high, and one of the reversible causes for that is acute massive PE. So that's the second question you will be asking yourself. The third question is, again, you will do a cardiac view during the pulse check. Is there cardiac activity? And what you're looking for in cardiac activity is systematic a contraction of the ventricular wall, and it will be, you have to assess, is there cardiac activity or no? And the fourth ultrasound that you will be performing here, where you will be looking at the lungs to look for pneumothorax and the abdomen to look for any free fluid in the abdomen, signs of hemorrhagic shock, for example, in a ruptured abdominal aortic aneurysm. So with this, you will have a systematic approach and you will be able to answer important questions to help address the possible reversible cause of your cardiac arrest. Because like I said, performing ultrasound may interrupt your CPR. And in this study that they actually asked the question, does ultrasound performed in cardiac arrest increase interruption of CPR? And this is a study that compared ultrasound during CPR, and they basically compared using ultrasound versus non-using ultrasound. 23 patients were enrolled, 19 of them had ultrasound, where 4 did not have ultrasound. And you will see the interruption of CPR or the pulse check in the ultrasound group was 21 seconds, while in the non-ultrasound group was 13 seconds. So what is the recommended pause for the pulse check? Yeah, less than 10 seconds. So imagine when you in the groups where ultrasound was used, this was doubled to 21 seconds, and this is not acceptable, because we know the longer the interruption, the less the perfusion and the worse patient outcome. So they concluded that the use of point-of-care ultrasound during cardiac arrest was associated with a significantly increased duration of pulse checks, nearly doubling the 10-second maximum duration recommended in current guidelines. Therefore, the same group actually, what they did is they implemented the CASA protocol, which is the Cardiac Arrest Sonographic Assessment Protocol that we discussed earlier, in their department for patients in cardiac arrest. So what did they do? This department actually recorded all of their cardiac arrests, and they implemented the CASA protocol in September 2017. And after they implemented the protocol, all of their cardiac arrests were recorded. So they had actually recordings of their cardiac arrest previous to the implementation of the CASA protocol and after the implementation of the CASA protocol. And they compared the pulse, the interruption of CPR in both phases. And they wanted to see, well, is the implementation of the CASA protocol help decrease the pulse check period? And you will see here, this is previous to the implementation of the CASA protocol. Only 10% of their cardiac arrest had pulse check less than 10 seconds. And you will see a lot of them, more than 60%, have interruption more than 15 seconds. After the implementation of the CASA protocol, you will see that the compliance to the minimizing interruption improved, and the interruption more than 16 seconds decreased to about 40%. So the study have shown that the implementation of a structured algorithm for ultrasound use during cardiac arrest significantly reduced the duration of CPR interruption when ultrasound was performed. So this is evidence that if you are planning to implement and incorporate ultrasound in your cardiac arrest, you have to do it with a systematic protocol to make sure that the implementation of ultrasound should not interrupt your CPR or prolong the pauses. So how should I optimize the CPR interruption if you're going to implement? These are few tips that I found that are helpful when you implement point-of-care ultrasound in resuscitation. First, using this protocol, the CASA protocol. I think protocol makes us more systematic, more standardized. Everyone knows what's going on, so it's very, very helpful. It also decreases the cognitive load on the sonographer. The second thing, this is the time for the most experienced sonographer to perform the ultrasound, because you are required to get the best images you can in less than 10 seconds. So this is really not an opportunity for you to teach on how to obtain these images, because we know that can take some time. So the most experienced sonographer should be performing the ultrasound. 3, you have to prepare parallel to the CPR. So the sonographer who is doing the ultrasound is not part of your CPR team. They're not doing the compression, they're not doing the drugs or medication or ventilation. This person should be parallel to the CPR team. Obtaining the echo, 5-second pause. And you want to try and prepare your ultrasound 5 seconds before they stop CPR. And this will be good when you actually collaborate with your CPR coach to make sure everyone is in alignment with the timing. And then remember I said when you obtain the images, immediately record, because you don't want to be interpreting your findings right then and there. You want to record and then evaluate your findings once CPR resumed. And then you will communicate the results with the team leader. And based on that, they will be, the treatment or management may or may not be changed. So these are very important, simple tips that it will help when you incorporate point-of-care ultrasound in resuscitation without interfering with the standard of care. The most important question is why? So if you're not already using ultrasound in arrest, should you use it? Is there benefit? Is there evidence that use of point-of-care ultrasound changes outcome? So one of the main reasons you will see in the literature cited for the use of point-of-care ultrasound is to help identify reversible causes. We all think, right, when we think of our reversible causes, the H's and T's. The H's, hypoxia, hypovolemia, acidosis, hypo and hyperkalemia. And the T's, thrombosis, tamponade, tension pneumothorax, toxin, and trauma. So what of these reversible causes ultrasound can help with? So definitely ultrasound can help you identify pneumothorax, tamponade, massive signs of massive PE, free fluid in the abdomen, IVC that can help you basically identify if there is hypovolemia or not. So definitely ultrasound will be helpful in identifying reversible causes. So we will go through some ultrasound videos and we will try and interpret them. So this is a right upper quadrant view, and you can see here is the kidney and this is the liver. And what is evident in this video? Here is this free fluid, which is anechoic free fluid in the Morrison's pouch. So in the right clinical setting, for example, if this is an elderly gentleman with a history of an abdominal aortic aneurysm and had a cardiac arrest, finding this may be suggestive that there is a ruptured aortic aneurysm intraperitoneally. And that can help guide your resuscitation by giving the patient blood and managing it accordingly. So this is one of the reversible causes that we know that you can actually tailor your management for. This is a second ultrasound video, and this is a lung ultrasound using a linear probe. And what you're seeing here, this is a rib with shadow, and this is a rib with shadow. And this white line is the pleural line. It's the white line between two ribs. Normally, the pleural line should be sliding. So in a normal ventilated patient who is breathing or is being ventilated, the pleura should be sliding back and forth with respiration. However, what we can see here, that obviously you can see some movement from the muscle wall, but there is no pleural sliding. So in the right clinical setting, this could indicate pneumothorax, and in cardiac arrest we're always worried for tension pneumothorax. Just be mindful that you are not scanning or you ruled out main stem intubation, because for example, if you intubated and it's a right main stem intubation and you scan the left lung, it will actually give you absent lung sliding because the left lung is not being ventilated. So after ruling out right main stem intubation, finding this indicates that this patient could potentially have a pneumothorax. This is another video. So for example, this is, if I tell you, this is actually a real case of a young male who was in the dialysis unit and he had a cardiac arrest in dialysis. It was a PEA arrest. They did CPR and they brought him to the emergency department, and we were very lucky because the patient immediately had RESC when he came. So you can see this is a subxiphoid view of the heart. And this is an IVC assessment. So what can you see in this video? In this video on the left, you see that the right ventricle really looks big, even bigger than the left ventricle. And what is very evident is that there is this huge thrombus in the IVC, and it's going back and forth very close to the right atrium. Based on these ultrasound findings, immediately after RESC, we were able to identify the potential reversible cause of this cardiac arrest, and this patient was actually thrombolized. So we saw the signs of right ventricular strain, which is enlargement of the RV, but also you can see here the clots that was also supported by this clot in the IVC. This is not very common finding, but the more you use ultrasound in your arrest, you will be able to find these rare but very important and high yield finding that you're able to actually tailor your management. Because if you don't see this, you think of so many other causes, especially in patients who are undergoing dialysis. This is another video. You can see here, this is a subxiphoid view. Obviously, there's no cardiac activity. But what can you see here? So this is the heart, this is the liver. You can see here anechoic dark fluid collection, but this is actually a clotted tamponade. So in the right clinical setting, you will know that this is a tamponade. It could be traumatic or non-traumatic, it depends on the history. But again, ultrasound can help you identify the reversible cause and tailor your management accordingly. Unfortunately, this patient actually did not make it and we were not able to resuscitate it, but we were able to know what is the underlying cause of the cardiac arrest. So I hope these cases were able to illustrate some of the reversible causes the ultrasound can help you identify when you incorporate it in your cardiac arrest management. So we said we're going to look for any signs of trauma or hypovolemia, tension pneumothorax, which is another sign of hypoxia, thrombosis, especially for signs of right ventricular strain, and cardiac tamponade. Another very important the reason for using point-of-care ultrasound is to identify if there is cardiac activity during the pause or not. And let me show you, these are two different cases, here on the left and on the right. If you actually perform your ultrasound during the pulse check and saw this video on the left, would you say there is cardiac activity? So you see that there is definitely no concentric movement of the cardiac muscle walls. Only you see flickering of the valves. So in this video, I would say there's no cardiac activity. However, here you can see that there is concentric movement, symmetrical movement of all cardiac muscle. And this is, if you see it, you will say, yes, there is cardiac activity. So why is this important? Is identifying cardiac activity making a difference in your outcome and the care for your patients? So here are a few examples, and this is very important. Do you think there is cardiac activity in this video? No. So you see the actually muscles of the left ventricle is not really moving. Only you can see some flickering of the mitral valve. So in this case, there's no cardiac activity. How about here? Definitely there is cardiac activity, but very, very weak. Probably that's why you actually cannot feel a pulse in this case. But however, there is symmetrical movement of the ventricular wall. So this is positive for cardiac activity. How about this one? Absolutely right. You can see very obvious cardiac activity with even movement of the valves during end of systole and diastole. So it's very important that when you do your cardiac ultrasound, the question of is there cardiac activity, yes or no? And we know that sometimes this can be very challenging, especially when you're right there and doing it. That's why recording it and reviewing the image during the CPR will be important. So in this study, is point-of-care ultrasound a reliable predictor of cardiac or outcome during atraumatic non-shockable cardiac arrest? So this is a systematic review and meta-analysis. What they did is they reviewed 10 studies of patients with non-shockable cardiac arrest and the use of ultrasound in them. They have had about 1,500 patients enrolled, and their main question was to assess the accuracy of point-of-care in predicting return of spontaneous circulation, survival to hospital admission, and survival to hospital discharge. And this is what they saw. So the rates of favorable outcomes for patients based on point-of-care ultrasound finding. And the main question they're trying to answer is there cardiac activity or no? So in cases where they had cardiac activity, they had 16.6% chance of having RESC, 10.8% had survival to hospital admission, and 1.3% had survival to hospital discharge. However, in patients with no cardiac activity, the percentage of RESC, survival to hospital admission, and survival to hospital discharge was lower than patients who had cardiac activity. And the presence of cardiac activity on POCUS, these are the sensitivity, specificity, and positive and negative likelihood ratio for RESC, survival to hospital admission, survival to hospital discharge. And it's very, very important to notice that this is higher in the presence of cardiac activity than non-cardiac activity. But what I want to actually highlight is, especially in this table, that patients who did not have cardiac activity, there is very low chance of survival to hospital discharge, but this is not zero. And this is very important for us to note. The study also showed that the presence of cardiac activity on POCUS compared to the absence had a diagnostic odd ratio of 16.9 for RESC, 10.3 for survival to hospital admission, and 8.03 for survival to hospital discharge. So having cardiac activity on ultrasound the patient has a more favorable outcome than none. And they found that in the asystole group, they demonstrated a sensitivity for ROSC of 26.1. However, in the PAA group, demonstrated a sensitivity of 76. So PAA, which we know has a better prognosis compared to asystole. So even PAA with positive ultrasound finding for cardiac activity have a better sensitivity for ROSC compared to asystole and cardiac activity. And this makes sense because this is also what we know. So cardiac activity on POCUS was associated with improves odd ratio for ROSC, survival to hospital admission, survival to hospital discharge in non-traumatic, non-shockable cardiac arrest. And POCUS should not be viewed as a sole predictor in determining outcome. This is very, very important. There's a lot of literature saying that using a point of care in resuscitation will help as a prognosticating indicator. So, for example, you do your CPR, you do your pulse check, and you put your ultrasound, you see no cardiac activity. That does not mean you have to stop CPR or terminate your resuscitation. You have to put your POCUS finding along with all the other predictor. So the time to CPR, how long is the downtime, how long is this resuscitation going, and then you can also incorporate your ultrasound finding, because we know that finding no cardiac activity, the survival of hospital discharge is very, very, very low when you compare it when you have cardiac activity. So in the updated guidelines for the American Heart Association, they recommend against the using point of care for prognostication during CPR. And that's because of this finding that there were 0.03% patients who had no cardiac activity, yet they survived the hospital discharge. And therefore, I think my recommendation would be is not to use ultrasound alone as a prognostic indicator. You have to basically use it within the whole picture of the patient, and make sure you incorporate the history, the past medical history of the patient, the history of the resuscitation, how long is the downtime, what was the actual rhythm, PEA versus asystole, and all of that. So ultrasound itself is not enough to be a prognostic indicator. Now, the last indication or why to use ultrasound is for pulse check. How many of you have been in a cardiac resuscitation where there's a lot of argument? Is there a pulse or not? You're questioning yourself. So this is increased or published literature of a prospective study found that the pulse check using carotid artery compression with ultrasound probe was faster compared to the manual palpation in the femoral artery to determine that there was return of spontaneous circulation. And that was significantly shortened to 0.44 times than the manual palpation. And this was statistically significant. So these are interesting uses of point-of-care ultrasound in cardiac arrest. So the three main reasons is reversible causes, to identify reversible causes and therefore tailor your management. You can use point-of-care for pulse check. When you have your pulse check, you will put your ultrasound on the carotid to see if there is pulsation. And you want to use it as a prognostic factor, but remember, you have to incorporate it within the whole picture of the patient. So what does the future hold for the use of point of care in cardiac arrest? There is increasing growing body of literature to support the use of transesophageal echo during cardiac arrest, and I think probably in the next 10 to 20 years, this will be probably standard of care in many hospitals. We know that transesophageal echo provides higher resolution images and therefore continue through the resuscitation. So you don't have to really bother and go through the compression zone. All you need to do is insert the transesophageal echo probe and you will get a continuous high resolution images. TEE requires a dedicated physician during cardiac arrest, so that's very important, and it also needs a specialized training. So if this was going to be implemented, a lot of physicians in the resuscitation should be trained to use it. The studies have not supported that there is a specific patient-oriented outcomes for the use of TEE in cardiac arrest, but I think the future supports the use of TEE because it gives you higher resolution images. It will be out of your resuscitation zone. It will probably not interfere with your chest compressions, but this should be, protocolized with appropriate training and getting the right equipment in the departments. So I just wanted to share with you where is this literature going, and probably this will be the future of using ultrasound in resuscitation. So to summarize, ultrasound in cardiac arrest, so we said when to use it. It is recommended to use it in non-shockable rhythm, in asystole and PEA. How to use it? We should use it during the pulse checks. However, we want to make sure we do not increase the CPR interruption. And then finally, why should we use it? To identify reversible causes of the cardiac arrest, you can use it for pulse check and as a prognostic indicator. However, you don't want to use it as a solo prognostic indicator, and you want to include it within the whole patient picture. I'd like to thank you very much for your attention, and these are the references, and these are my contacts, so feel free to actually contact me and I'll be happy to answer any questions.